Hello everyone. Let's proceed with the series of videos on intestinal obstruction. Today we'll read about obstruction due to adhesions in the bands. This is the picture showing a single band, and you can see proximal dilated bowel and the distal normal bowel. So the most common cause of intestinal obstruction is adhesive obstruction, and there are lifetime risk of readmission up to 4% due to recurrent adhesions. And when the patient is again and again admitting, there is 2% risk of having laparotomy. So adhesions start to form within the arts of abdominal surgery. So keep in mind, it is not like patient will develop adhesion after only 2 months or 4 months. Fine. So the mechanism is any source which causes peritoneal irritation cause local fibrin production, which in turn cause adhesion between the opposed surfaces. So what happens next? If there is adhesion, it may disappear when the cause is removed, or it may vascularized and replaced by mature fibrous tissue, which is difficult to manage. Now, causes of intra-abdominal adhesions are inflammation, acute inflammation. What happens is that there is a site of anastomosis, there is acute inflammation over there, then there is reperitonealization of the raw area, there is again trauma, there is ischemia, and there is addition of omentum, maybe other raw surface area, which can lead to obstruction. Again, foreign material like talc, powder, starch, gauze, silk may cause inflammatory response and lead to adhesion. Infection like peritonitis and tuberculosis, again a cause of obstruction. Crohn's disease, which is a chronic inflammatory condition, again can cause adhesive obstruction. Some patient may be receiving radiation therapy for some diseases. This may also cause intestinal adhesive obstruction. Now, how to prevent adhesion? All the adhesions can't be prevented, but yeah, post-op adhesions can be prevented by a good surgical technique. Washing of peritoneal cavity with saline when there are clots. If they are removed, there are less chances of adhesions. Also, minimal handling with the gauze pieces, because some fibers may be stuck and there can be some serosal injury due to rubbing with the gauze. Okay, what can you do next? When you anastomose a surface or you repair a surface, you can cover it with the omentum. So the site of anastomosis is covered and the chances of obstruction or the adhesions are decreased. Adhesions can be fibrinous or the fibrous. The fibrinous one are the flimsy one, the early ones, and they can be dissected very easily. The fibrous or the late ones are very difficult one, and this will cause a problem while operating. Now, bands. A band is you can say structure that we have seen the first image that causes obstruction, and there can be multiple bands. Now, if you remove the particular band, the obstruction may go, and you can leave the other bands which are not the culprit. Now the causes are congenital, like obliterated vitellointestinal duct can form a band and lead to obstruction. A sting of band following previous bacterial peritonitis can be there. Also, a portion of greater omentum can usually adhere to parietes and may cause the obstruction around it. Now, the treatment is, it is very interesting. Any case of obstruction, you can give a conservative trial of 48 to 72 hours with intravenous fluids and nasogastric decompression. If it is failed, you may proceed with laparoscopic surgery or laparotomy, and band may be divided multiple or a single one. If you think there are multiple bands and the culprit is only one, you can divide one and leave the others, but you may have to divide multiple bands when there is acute angulation. Now, if it is surgery which is to be done, The name for that surgery is adhesiolysis, and definitely recurrent obstruction, recurrent adhesiolysis is now the standard treatment for the adhesions which are not relieved on the conservative management. You should remember some names for historical point of view which may be asked in MCQ, like Noble plication, Child Philip transmural plication, intestinal intubation, which were used earlier to treat the obstruction. Thank you so much. We'll meet in the next video. Till then, bye bye.